Moving on to the plenary session, we have the fifth plenary session of ISOT 2021 on transplant oncology, new kid on the block. May I invite the speaker, Dr. Sudhindran S. I'd like to now invite the chairperson for this plenary session, Dr. Tugaram Jamale. Over to the chairpersons.
Thank you very much for this privilege of online DIAS, ISOT. My topic is transplant oncology, a new kid in town. So the natural rule of solid organ transplants is that do not perform transplants for malignancies. Now the reason is obvious, high risk of recurrence due to immunosuppression because your immune surveillance is impaired, and therefore even if one malignant cell is left undetected, its growth will be enhanced because of immunosuppression. Additionally, it supports oncogenesis by many means, including viruses. If you look at kidney transplant recipients, the malignancy is more common than general population, and I was surprised to learn that malignancy is indeed the third common cause of death in renal transplant recipients. Most guidelines therefore suggest that there should be a minimum 2 to 5 year remission period from malignancy prior to any transplantation. And this remission period, whether it is 2 years or 5 years, depends on the aggressiveness of the cancer. Exceptions are, of course, bone marrow transplantation, where they are mostly done for malignancies, and of course, liver transplantation for hepatocellular carcinoma in cirrhotic patients. But then, if you look at liver transplant, out of the first 10 that were ever done, 6 were for malignancies. And the rationale was very appealing and indeed intuitive, because only a transplant can have a resection of the widest possible margin. It will, of course, cure the cirrhosis, which is the background for most hepatocellular carcinomas. And there is no other way that you can address the field effect of HCCs, because it is multifocal, and therefore, unless you take the whole liver out, it's not going to work. And it was deemed to be the ideal solution for hepatocellular carcinoma. Therefore, large number of liver transplants were done in the late 1970s and early 1980s for hepatocellular carcinomas. But then they found that the recurrence was abysmal and therefore very bad results. And soon, in 1989, HCC was declared as a relative contraindication for liver transplantation. Till this gentleman, Vincenzo Mazzafero, detected, or he found out the reason why these actually occurred. He found out that it was a vascular invasion. It could be macro, it could be micro. That was the reason for this recurrence, because through these vascular invasion, these malignant cells were escaping outside the liver, and they were actually coming back. The problem is, how do you detect this micro or macrovascular invasion? Unless you do a biopsy. Even if you do a biopsy, sometimes you can miss it. Then he came out with the surrogate markers of size of the nodule, or the number of nodules, which are now known as the morphometric criteria, or the most popular. There are many. The most popular is, of course, Milan criteria, which means a single tumor less than 5 centimeters, or 3 tumors less than 3 centimeters, without any macroscopic vascular invasion. That is evident vascular invasion on your cross-sectional imaging and evident extravascular spread. They will actually be the best result for malignancies. Now, even beyond Milan, so the transplants were done for these early HCCs, and he came out with this absolutely superb recurrence rate, less than 15% over 4 years. That means survival of 85% for HCC patients within Milan, which is as good as doing transplant for any other indications, any other non-malignant indications. But then if you look at the slide, you will realize that even outside this Milan criteria, the 4-year survival was nearly 60%. And no other modality can give such a good result for hepatocellular carcinoma other than transplantation, whatever you do. Therefore, why don't we transplant all HCCs? Because that gives the best results. And the answer is obvious, because there's a long waiting list. I mean, you have this waiting list, a huge waiting list, and the number of donors are way down there, and there's a huge gap which is causing this problem. So what has changed now? Has anything changed? I think few factors did change. Most important was probably the increase in the organ donor pool. A lot of marginal donors were actually being used as donors. Previously would have been refused. non-heart beating donors. There's a new thing that's come up in the last few years, and large number of non-heart beating donors are there. In fact, it's become the major pool in Europe. And then, of course, living donors in Asia. Additionally, there were better immunosuppression. So you could see that you could manage immunosuppression without getting rejection and without getting recurrence. So some degree of tolerance as well. A few more factors. Importantly, the development molecular profiling and systemic therapies based on those. There were good neoadjuvant treatments for downstaging tumors that are actually outside these criteria. And there were also adjuvant modalities in case recurrence occurred. Moreover, HCC, so an exponential rise in the numbers. In fact, it has now become the third most common cause of cancer causing deaths all over the world. It was only seventh or eighth, like 3-4 decades ago. This is probably because of the increase in non-alcoholic steatohepatitis. In addition to this, then other indications for transplantation, such as hepatitis B and hepatitis C, has plummeted because of effective medications for these treatments. So because this large number of patients with CZ were actually on the list for transplantation. And of course, the results for elective transplantation was much better. So people are less reluctant to put them on the transplant list. So the multidisciplinary team became much wider now. Initially, the usual transplant team, which was consisting only of hepatologist and anesthetist in addition to the surgeon, now included a medical oncologist, a radiation oncologist, a pathologist, an immunologist, and a basic scientist as well. And the approach was, no, I will not give up. Tumor biology is the king. We need to find out that the tumor biology is a problem. Forget about the size of the number. And this was the predominant thought. So the HCC, which were not transplantable by the so-called standard criteria, they were not valid any longer. But if you look at the DDLT versus LDLT, the DDLT predominant nations like North America, Europe, the gap was still wide despite the increase in numbers. They still have to stick to the morphometric criteria. However, in LDLT predominant nations, predominantly Asia, they've expanded the criteria, some of them drastically. So now the choice is based on biology. So tumor markers, for instance, alpha beta protein, PIFCA, or prothrombin induced by vitamin absence, they are very good markers telling you about the aggressiveness of the tumor. Likewise, the PET scan, how is the uptake on PET scan? There's no uptake, means it's less aggressive. How do they actually respond to treatment? Your ablations, or radiotherapy, or even chemotherapy, including immunotherapy, programmed ligand inhibitors, etc. And even the previous absolute contraindication, which was vascular invasion, either to portal vein or hepatic vein, evident on a CT or MRI, there were no longer absolute contraindications. There are people who are transplanting for patients with portal vein thrombosis by previous treatment and getting to the thrombus of whatever way, and gives very good results. So current modes is, rather than select who to transplant, it's weeding out those and filtering those who are futile to transplant. So you widen the umbrella so much that as many more people can come under the umbrella, and you choose those who are really bad candidates. Others, give them a chance, see what can be done. And there were other malignancies that were coming up. And the major surprise, which people never thought in their wildest dream, was colorectal liver mets. Because, who would ever transplant somebody with a primary elsewhere and metastasis to the liver? If you look at the surgery for colorectal cancer and the follow-up, almost half of them will develop liver metastasis, and which is a usual reason for death. Sadly, liver resection is the only curative treatment, and of course, and sadly, only 30% are resectable, which means 70% of colorectal liver mets are unresectable, and which leaves us with a 5-year survival of less than 20%, 18% is a 5-year survival. And therefore, the thought about this liver transplantation, interestingly, it started in Norway, mainly because they had an excess of diseased donor livers. I mean, they, in fact, they could export livers sometimes, and there's hardly any waiting period for cadaveric donors in Norway for liver transplantation. Their only problem was selecting appropriate patients, and they went through a large number of trials and tribulations, etc. And they came out with the Oslo score, predominantly again to predict the futility. That is, you weed out those who are going to do badly following a liver transplantation for liver mets. But their criteria is largely intuitive. Size of the tumor, if there's a huge size, they're not going to do well. The CEA, which again is a tumor marker, carcinoembryonic antigen, telling you about the aggressiveness of the tumor. A short time from primary surgery means a probably large amount of metastasis lying around in the body. And again, poor response to chemotherapy means they're aggressive tumors, and probably they will come back whatever you do. And therefore, the results in the selected group published from Norway have shown a 5-year rate of 60%. And this is despite recurrence elsewhere, mostly pulmonary. Still, they got a good quality life, and therefore this has become another indications for liver transplantation. In India, because liver mets from colorectal primary are predominantly a photo oncologists who are probably still not convinced about it. I don't think that many are doing it. I mean, we from Amrita have not done any. I'm not aware of anybody from India having done it for colorectal mets, but I think it's only a matter of time before we find out the right patients and do it. Other malignancies, cholangiocarcinomas, which are only could be done on a trial basis, hepatoblastomas, hemangioendothelioma, neuroendocrine tumors, all these metastases, and they are all being included in the indication for liver transplantation. So it's actually become quite a widening field. Now, even following liver transplantation, this transplant oncology has made a huge impression. For example, immunosuppressions. Now we do know that low levels of calcium inhibitors are important to prevent recurrence. So in order to keep the levels low, we add other immunosuppression, like usually mTOR inhibitors. And interestingly, it is like hitting two birds with one stone. It not only gives immunosuppression to prevent rejection, but it has got anti-angiogenic and anti-proliferative effect. And therefore, it may actually be a tumor suppressor agent as well. So currently, sirolimus and everolimus, we do use everolimus as a standard in all patients transplanted for HCC. There are some soft evidence that it may be better, but still good evidence is lacking. And other modalities to tweak your immunity. So essentially, when you give immunosuppression, because immunity comes down, your cancer cells will go up. So you have to tweak it so that the immunosuppression recognizes that the liver, which is foreign, is actually self because you need it, whilst the tumor cell is non-self. Now, how do you recognize that? Interesting experiments are going on with infusing natural killer cells from the donor liver and developing that and infusing into the recipient at the time of transplantation. I think futurely will tell us how all this will transfer. So I think the era of transplant urology has just begun. And I'm sure it will be there for all fields, including, for example, somebody with bilateral renal tumors. Well, nowadays, what you do is you do bilateral nephrectomy and put them on the dialysis, and then later on consider transplantation. But maybe, now there may be a time to remove both kidneys and do a kidney transplant at the same time. Will it help? I'm positive it will. First of all, it does encourage multidisciplinary cancer care. Secondly, it's likely to extend your limits of all your conventional management. And thirdly, linking tumor and transplant oncology in many ways, like we said, it will develop a lot of future research, maybe into developing tolerance, etc. And of course, next generation research into biomechanics and genetics of cancer are likely to happen in this field. Thank you very much.
Thank you, Sudhindran sir. Dr. Rajesh here.
Hi, Rajesh. Hi.
Hi, sir. It's a wonderful talk, as usual.
Thank you.
Very lucid. So the essential difference regarding the transplant recurrence or maybe incidence of transplant kidney versus liver is that often, as you rightly said, the indication for transplant in the hepatology scene is maybe starting with the malignancy itself, whereas in kidney it is not so. I was fortunate to co-author a chapter on malignancy after transplantation in the Oxford Handbook of Kidney Transplantation, authored by Dr. George Abraham. He's here. So we found that the incidence of transplant, the incidence of transplant in the post-kidney transplant scenario comes up in a big way following a significant longevity following the graft. So the longer the graft survival, the possibility of immunosuppression longevity is more, and the patient is likely to go for likelihood of malignancy. So as you said, the crux is screening with imaging, and there are certain protocols which we should follow for transplant recipients to screen for possible malignancies in the first year, maybe 3 years, 5 years, etc. So that we can, if at all there is a malignancy, we need to probably pick it up early and maybe go ahead with measures accordingly. Thank you very much for that, for enlightening talk. Thank you very much.
Thank you, Rajesh. I think probably the immunosuppression modality and the way it acts also may change, so
Very
that
true, very true.
cancer occurrence does come down. Thank you.
Thank you very much, sir. Thank you.